Să începem această sesiune din rațiuni organizatorice. Due to organizing and very tight flight schedule, we need to get started as soon as possible. How to manage adult CF este sesiunea cu care urmează să începem. O avem pe scenă alături de noi pe doamna profesor dr. Camelia Pescaru, îl așteptăm și pe domnul dr. Cristian Oancea să se alăture, iar domnul profesor Andrew M. Jones va ține următoarele 3 sloturi de prezentare, unul după altul, după care dânsul are avion de prins. Așadar, îi dau cuvântul imediat dânsului, ține toate 3 prezentările și încercăm la final să acoperim o sesiune de maxim 10 minute de Q&A, deja suntem într-o mică întârziere. Așadar, dacă toată lumea e pregătită, profesor Andrew M. Jones, e rugat, can you please join us on the stage? Stage is yours for the next 3 slots. In the end, you ask him if they have any questions that you might answer or a feedback from our chairman, and then we keep going. Thank you so much. Aplauze pentru domnul profesor, dăm drumul. You have this ready, have all yours. See if I can have this.
That'd be great. So, hello everyone and welcome back after lunch. I'm Andrew Jones. I'm an adult CF physician based in the Manchester, United Kingdom. And it's a real pleasure to be here at this meeting. So I'm going to talk to you, I'm afraid you've got 3 talks from me, so we'll run one into the next and the next. Hopefully you won't get too fed up with me. But I'm going to talk today about specifics of adult care, first of all, and I'm going to perhaps reflect a little bit about the past, but the present, but also a little bit about the future, and tell you our own experiences. There we go. So much has changed in cystic fibrosis. Much has changed over the last 5 decades. So we used to see children like the top picture, but now, with the fantastic care we're getting in pediatrics, we're finding very healthy young children. Slow. It's slow. And there's been improvement over the decades with treatment interventions, but importantly, underlying this, delivery at CF centres by a multidisciplinary team. And these have been additive, and treatments are still emerging. As a consequence, the mortality rate in cystic fibrosis has been falling. And we've seen the slide before, the median percentage survival age is increasing, and this is median percentile age from the UK CF registry. And the age distribution is changing. And the red bar here that I've inserted on this graph delineates people who are 40. And to the right of that, people who are over 40. 40 used to be old age in cystic fibrosis, but this is now evolving as well. And we have over 100 adults at our centre who are 40 years and older. And as a consequence, the age distribution is changing with these advances in care. And you can see from the UK, 2011, a decade later, how the age distribution has changed. Fairly similar in pediatrics, but in adults, the bulge is moving upwards. We're seeing more and more older patients. Patients are surviving for longer. And the age distribution in the UK is vast between people with CF. But we recognise that in Europe and less well-resourced countries, there is differences between European nations at present. But hopefully, these differences will start to merge. At our centre, in the 1990s, 55% of our patients were adolescents. They were teenagers. At our centre now, 3% of our population are teenagers. 6% were aged over 30 years in 1990. Now, 61% are aged over 30 at our centre. So CF is changing. What is it about older adults that are changing? Well, as I mentioned before, age over 40 was traditionally taken to define long-term survival in CF, but this cohort is evolving. If we look at another UK CF centre, the Brompton, who published in 2008, of their patients over 40, 30% were homozygous for Delta F508 and 80% were pancreatic insufficient. Now, in Manchester, when we look at this, similar demographics, but it's 40% are now Delta F508, 85% are pancreatic insufficient. So the older patients, it is those with classical CF who are surviving for longer who are driving these numbers, not new diagnosis. But there are late diagnoses as well, and we shouldn't be complacent with people whose cystic fibrosis is diagnosed late. This is an American study where patients who survived up to 40 years old, for those whose CF was diagnosed in childhood, they survived to 53. If it was adults, it was 68 when the CF was diagnosed. So they did better, but it was still a decade less than the general population. And again, another study showed that if CF is diagnosed in adults, a quarter had died within 10 years of the diagnosis, and a third had died within 15 years. And survival was worse if your diagnosis was late, above the age of 40, or if you had lower lung function at diagnosis. And most of these patients who were diagnosed late eventually did die of respiratory failure or complications of lung transplant. And patients who had lung disease, who survived beyond 40 to 50 years of age, had a similar trajectory, downward trajectory, in their lung function if they had underlying lung disease as those who were diagnosed in childhood. So diagnosis late in adulthood is not a diagnosis of benign disease if there's already lung function damage present. And we know that adults with cystic fibrosis are living with reduced lung function, even though they're surviving longer. And if we look at the American figures here from the American registry, the number of patients who are living in the red bars with severe lung function is quite significant, about 10 to 15%. And this is really before the onset, because it's 2002 figures, before the onset of CFTR modulators, where these numbers will probably go up. So we'll be looking after a lot of adults who still have significant disease, who are survivors. What does that mean? Well, it has implications for lung transplantation. People will be having the transplants maybe later in life. But studies have said that there's a higher survival in older patients who have lung transplants. Lower mortality due to allograft failure, but complications can be different. There was a much higher incidence of malignancy in the older patients who undergo lung transplant than the younger patients. And older patients are more likely to have underlying diabetes, hypertension, renal disease, osteoporosis, and colonic polyps as a precursor to bowel cancer. But also with modulators, we're now grappling with an evolving phenomenon is when should you list the patient with severe lung disease for a lung transplant if they've been stabilized on a modulator? And what is the optimal timing so they gain the benefits of a lung transplant? We should not forget in adults that many adults will still need intravenous antibiotics. And these are figures from age groups. And you can see the number of adults needing an antibiotic is no different to the number of children. But we need to think, if adults are surviving for longer and longer, about the consequences of actions we may undertake. This X-ray is one, and the picture are one of our patients. And this patient now has severe vascular narrowing. She's had a port all her life, or a series of ports. And now a superior vena cava has closed off. And you can see the dilated veins on her abdomen, and actually, on the X-ray, quite difficult to see, but there are stents in the vena cava to try to maintain the vena cava. So we need to think now, long-term with the patients. They will survive for many, many years, so our actions and our treatment strategies may need to evolve a little. As our patients are surviving for longer, they will start experiencing the general consequences of aging. that affect us all. They can be cardiovascular disease, renal disease, osteoporosis, osteoarthritis, diabetes, malignancy, hearing impairment, weight changes, metabolic changes. But these are also mirrored in CF as a CF-associated problems. So how will our CF patients be with these added complications simply from aging? Will this be a super added effect from having cystic fibrosis? And we need to adapt our strategies, bearing this in mind too. We see from American figures that weight gain is actually once the purported challenge in CF, but now actually it is a challenge in CF, but as much the other way. And from this graph shows the number of patients in the North American registry who are overweight. And this has been increasing year upon year upon year. And these figures are pre-modulation. This is the UK figures. So in the UK, this is the body mass index for adults from 2018 to 2021. And what you can see is at the bottom of these graphs, in very light grey, are the number who are underweight with a body mass index less than 18.5, ever decreasing again. This is before modulators. But the number in the top, which is a body mass index of greater than 30, so obesity, is increasing and increases as well as the patients age. There's more obese patients in the older group than the younger group. So this is an ongoing challenge and an evolving challenge in our patients. Many of our patients who are traditionally taking a high-fat diet having to adapt if they're put on modulators when they're already gaining weight. This is a great challenge for those patients. But it's a challenge that we must rise to because of the associated problems here with hypertension, diabetes, to name a few. This is a study from from a European centre with 134 adults taking ETI for just 1 year. Sorry, it was at St. Louis, it is North American. There was an improvement in their diabetic control, HbA1c, but changes in their lipid profile. But you can see on the bottom graphs that actually hypertension started to develop, or the blood pressure was becoming raised in these patients, and they were gaining weight. So modulators are also changing this aspect of cystic fibrosis. And with increased weight, there's increased predisposition to diabetes. But what will diabetes be in many years for older adults who are overweight? Will it be type 2 diabetes? Will it be CF diabetes? Will CF diabetes in these patients be slightly different? Perhaps. It's an evolving picture. Modulators seem to stabilize HbA1c, but many of the patients are gaining weight. We know that macrovascular complications are relatively rare in cystic fibrosis at present, but we know microvascular complications, retinopathy, nephropathy, neuropathy, and gastroparesis are encountered and are common. And patients who are living longer will now be living longer with diabetes. And as you live longer with diabetes, optimal control will be important to try to prevent these complications developing. And it could impact on renal disease. We know adults with cystic fibrosis are at risk of other insults to their renal tract. We see a lot of renal stones in our adults due to malabsorption. They're oxalate stones. Many of our adults have diabetes, but many have been exposed and are still exposed to nephrotoxic medications. So we perhaps have to bear that in mind as well when we're administering medication to our patients, as well as other factors like sepsis and IgA nephropathy. The literature suggests the prevalence of chronic renal disease is approximately 2% in adults, but it is rising and will continue probably to rise as our population survives for longer. This is European registry data of kidney transplants, and now kidney transplants are being performed in adults with cystic fibrosis, much more than adults and children. And you can see the bars here. The older adults, 13 in 1 year. At our centre in Manchester, in the last 5 years, we've had more kidney transplants than we've had lung transplants. They're all single figures. So we've only had 1 lung transplant, but we've had 3 kidney transplants. And this is an evolving area for cystic fibrosis. So we need to project in the future how to protect the kidneys for a lifelong protection. And of course, we know that aminoglycosides, intravenous aminoglycosides, are associated with effects on the kidneys. So perhaps our antibiotic strategies may change over time too. But aminoglycosides also affect hearing. And we know from studies that there are high rates of hearing impairment in the CF population, especially in older adults. And this is something that perhaps we should be starting to screen for, if we're not doing it already. It tends to be a sensorineural hearing loss. The sensorineural loss increases in the general population with age. So again, people with cystic fibrosis may be at increased risk. Hearing loss is a risk factor for anxiety and depression. Again, prevalent conditions in people with cystic fibrosis. So we may need to think about our treatment strategies and adopt screening. And screening for adults is important. What about cardiovascular disease? The above is a paper which suggests that people with cystic fibrosis are at increased risk of cardiovascular disease. Although there were other studies, this is a European study where 14 patients over 40 underwent coronary artery catheterization, and none of them had any ischemic disease. None of them had coronary artery disease. So it's an area where we need to find out more. What is the true risk for cardiovascular disease? There are potential risk factors in people with cystic fibrosis. Increased arterial stiffness is encountered. They're more likely to have diabetes, more likely to have abnormal lipid profiles, but lower systemic hypertension. But CFTR modulators may be attenuating this risk. They may be decreased systemic inflammation and improved glucose control. But we might be seeing an increase in hypertension, hypercholesteremia, and an increased weight gain. So again, the cardiovascular risk is going to evolve, and we need more long-term studies to truly define what this is. Bone health is also important. So we all know that bone health deteriorates as you get older in the general population, but bone health in many of our patients is already subnormal. So we will need to screen and adapt for this and screen our strategies to protect the bones for people who are going to live long lives. Musculoskeletal problems, they increase and are generally age-related, including osteoarthritis, gout, sarcopenia. But we also have CF arthropathy, and gout is more common in cystic fibrosis. So as our population and adults age, we need to delineate if there's joint pain, if it is related to a CF arthropathy, or if it is osteoarthritis related to age and wear and tear, or even if it is other non-CF inflammatory conditions. And we now work very closely with our rheumatologists to try to delineate these. And some patients who we thought might have had a CF arthritis actually have turned out to have rheumatoid or systemic lupus as the underlying cause of their joint pain. But this requires strong links between the CF-MDT, musculoskeletal physiotherapist, rheumatology, and occupational therapy teams as well to deliver the best care. What about liver disease? Liver disease was thought to be childhood onset, and if you got away without having liver disease in childhood, you won't develop liver disease. But studies are now showing that there's a new cohort of adults delivering cystic fibrosis liver disease with a greater proportion of non-cirrhotic portal hypertension, with a median age of onset in one study of 37 years, and potential cases of nodular regenerative hyperplasia associated with chronic drug exposure has also been described. So again, this is an evolving area, and so hepatic steatosis, already seen in CF, becomes more common in diabetics and people with excess weight. So that is likely to change and evolve too. Gastrointestinal disease in the older adults, you find a decreased GI transit time in people who are already perhaps predisposed to constipation and bowel blockages. You get a gradual decrease in exocrine pancreatic function in some of the older patients who are pancreatic sufficient. So we need to watch that older population who are fortunate enough still to have a function in pancreas to make sure this does not happen. But there is also an increased frequency of GI cancers, small bowel, pancreas, biliary system, and colon. And we know from the American studies that colonoscopy screening does show an early instance and progression of adenomas. And the CF Foundation has produced this schematic diagram for screening for polyps in adults with cystic fibrosis, suggesting all people with cystic fibrosis above the age of 40 should have colonoscopies to screen for these polyps, and they should be repeated every 5 years, or every 3 years if a polyp is detected. For people in receipt of a solid organ transplant, the age drops from 40 to 30 years. And we're currently starting to do this in our centre. But we also know depression and anxiety are prevalent in the CF population. And we need to ensure, with all these changes that are happening in CF, we are there to support our patients. And we have a strong contingent of psychologists and social workers at our centre that try to help our patients adapt to these new changes that they're experiencing as well. But we should not forget what really matters to patients. What matters to patients? Their education, their careers, family, leisure. And as they will likely now, the cohort who are being born today are going to live much longer and much healthier lives. We need to adapt our advice and our careers advice. We need to adapt not just for their career, but their life after their career for many patients, for in retirement. And if we look at the social characteristics of people with cystic fibrosis in the United States and how that has changed, you can see the numbers in green between decades in 2002, 2012, 2022, who are married or cohabiting, and the numbers in blue who have a university degree. This is changing. Perhaps this is changing quicker than the other aspects of medical care that I've already highlighted. And within this graphic here, with employment, most adults with CF in the States were either employed, part-time employment, and several, not insignificant numbers, actually had survived and were now in pensionable age. Life is also changing for the patients on modulators. This is the number of pregnancies in women with CF, and perhaps does coincide with the advent of CFTR modulation, with a doubling of number. So patients now who perhaps were never thinking of being mothers themselves are now realizing they can be mothers, and the number of pregnancies are substantially increasing. So we need to build that and links with our obstetric department in at an early stage of people's lives. This is one of our patients. This is Marie. When Marie was born, she was told, or her parents were told, that she was unlikely to survive to adulthood. But this is Marie, married with a child. And the child growing up, who is now far bigger than Marie. So how should CF teams evolve and adapt? Well, we need to develop adult centres and increase capacity at adult centres, and I'm going to talk a little bit more about that in my next talk. We need to make sure that we have the core disciplines that we've already heard about earlier today, but also think about how other disciplines can help us, such as occupational therapy. And we need to just continue to build up and educate other specialities, for example, renal medicine, and perhaps think long-term about age-dependent problems, but age-dependent screening for complications, and evaluate treatment strategies. These figures show that the numbers of children are relatively static, but the number of adults are increasing. And again, this is the UK figure. There is a projection with observed numbers in 2017 in the UK population and projected numbers for 2030. And you can see that slope on the light grey graph has gone. There's now a bulge, and the bulge is the children who have moved to adulthood and are surviving, and this is before modulators. So this is delivery with multidisciplinary care at CF centres. and the main crux to the development of ongoing care for our CF population. The American CF Foundation have made this projection for the future for adults with cystic fibrosis living in America, that there will be a proportion in continuing need in 20 years of care, with advanced lung disease in yellow, with continuing need in the light blue, but a greater proportion of adults in the darker blue bar who are far healthier. I will talk more about this, our own centre, at a later talk, but this is where our centre was born, in Monsall Hospital. We were born in an infectious disease unit in a tiny hut with 19 patients, but moved to another hospital in Manchester in 1997 and then expanded that. So as our elder population has grown, we've had to develop a centre and expand that centre. We also have medication issues in older adults too, with the addition of non-CF treatments sometimes coming into a burdensome CF regime. So these may be statins as people develop as they get old and they are screened for ischemic heart disease. They may have a statin added on, or other conditions too. This is Charles, he's one of our patients, and these are the conditions with his cystic fibrosis has affected him. But Charles also has these conditions. These are not related to his cystic fibrosis, and the majority are not, but related to general aging. So this is an ongoing challenge as our CF population evolves. So developing CF centres and linking our knowledge and keeping with registries will help us understand these problems, to adapt for the future. So in summary, the population of older adults with CF is growing and increasingly comprises those with what we would have termed classical cystic fibrosis. These are not adults who are being diagnosed who otherwise wouldn't have been. It is the majority are people who wouldn't have survived, who are now surviving with a much brighter future. But this population will experience complications related to general aging and related to their cystic fibrosis. These risks will probably evolve with CFTR modulators too. So we as CF teams will probably need to evolve and adapt to meet the needs of an increasing adult population and older adult population as well, to minimize the iatrogenic complications, to adapt our screening programs for the onset of these complications, and to address medical and psychosocial implications of aging with cystic fibrosis. This is our team in Manchester, and this is our centre. So thank you. Okay, so now I'm going to talk about infection control in cystic fibrosis. And again, I'm going to look back as well as forward for this talk. So these, in the 1980s, these are papers that were published with noted, as it was then, Pseudomonas capacia. Now, Burkholderia capacia, then Burkholderia capacia complex. But an organism that seemed to be increasing in prevalence. And patients who harbored this organism had a worse outcome. Studies showed that the reason it was increasing in prevalence at CF centres was due to cross-infection. This was a combination of epidemiology and microbiological screening of isolates with typing of isolates, showing it is the same strain spreading between patients. And it was this that really brought to the forefront CF-specific infection control and the necessity of fastidious infection control for the health of our CF patient population. We recognize some of the profound effects this has because national and international conferences were discouraged, as were holiday camps. And these were recognized for all their well-being and mental health positives for the CF population at the time. And these were abandoned. But they did lead to success. So these are our own figures, and you could see in the 1990s, the mid-1990s here, this is the instance of Burkholderia capacia complex at our centre. Beforehand, there's an instance and prevalence, relatively low, and this was natural acquisition of individual strains from the environment, not due to cross-infection. But in the 1990s, our patients were encouraged to mix, and an epidemic strain came amongst them. And we had a dramatic increase in instance and subsequent prevalence to nearly 1/3 of the patients in Manchester harbouring Burkholderia capacia complex, the majority of which, subsequently we find out, are Burkholderia capacia. And you can see, subsequent to the infection control measures that were instigated, that the incidence drops off markedly in the lower darker bars. The prevalence sadly also drops, and the prevalence drops because of the virulence of this organism that led to a decreased survival for those patients who acquired it. Now we have a very stable prevalence, and when a new infection happens, we work with microbiology and we try to work out whether this is cross-infection or just acquired from the environment. And I'm pleased to say that all, in the last 10 years, have been acquired from the environment. They're all individual strains. And as such, infection control guidelines were developed by many societies. So this is the UK, this is Australia, I think, and North America. But other countries have these guidelines too. The importance of the guidelines are that they were multidisciplinary, and they also involve patients and their carers. There were consensus, and I will talk more why they are consensus, with as much evidence as possible, but consensus. And importantly, all these guidelines I'm showing now are revisions of earlier versions. So as we learn more and more, we've adapted these guidelines. A bit like in my earlier talk, CF is evolving and we're adapting all the time. What are the potential routes of spread? Well, they bear this in mind. There can be direct contact from person to person, indirect contact, such as if the patient shared a nebulizer or other equipment, but also droplet and airborne transmission. But the evidence and effectiveness for infection control has challenges. The evidence has a challenge by ethical limitations. We cannot undertake studies deliberately putting people in harm of acquisition of infection. The effectiveness, when measures are put into place, usually it's more than one measure. Usually it's a bundle of measures. Which is contributing, which is not, which is contributing the most is often unclear. And the measures required may differ from pathogen to pathogen. And hence, we learn more as more is reported, but it is still a consensus of measures. And it is also important, this is a quote from the US Infection Control Guideline from 2013. The goal of this guideline is to reduce substantially the risk of transmission and acquisition of pathogens while recognizing that the risk is unlikely to reach zero. But it is important to be as meticulous with infection control and to keep our patients as safe as possible. The study below it is a study from the Danish CF Centre in the early 1980s when they recognized there was cross-infection with Pseudomonas aeruginosa amongst their patients. And what happened there is the patients who still attended the centre, despite this cross-infection, had a better outcome than those who stayed away. So CF centre care is extremely important. We should not stay away from CF centres because of perceived risk of cross-infection. We should be able to counsel our patients, educate them, and try to reassure them, but we must also have very good practice to be able to reassure them too. In the UK, there are 5 pillars in our infection control guidelines. Basic standard infection control and basic hygiene, and we heard about that this morning in some of our talks. Education, education of staff, education of patients and their carers, and also education of other people who might visit our unit, such as cleaners or anyone who's come to our ward, of the meticulous infection control that is necessary. In the UK, most infection control is a basis of, for some centres, segregation by known pathogens, such as Pseudomonas, Burkholderia capacia, M. abscessus, or MRSA, but also with individual isolation within that cohort. One of the other pillars is eradication of early infection, so treatment regimes to eradicate early infection. But for that, you need good microbiological surveillance, so you pick up an infection. Microbiological surveillance to enable eradication of early infection, but also as a check of how your infection control is performing, a quality control. We know from studies that Pseudomonas can be eradicated if treated early. Plenty of studies, and most regrowths are due to a new strain. But we also know there's Pseudomonas cross-infection at centres and at holiday camps. In these studies, Pseudomonas was not isolated from the inanimate environment of a CF centre when there was ongoing cross-infection, but was isolated from room air when the patients were present. And segregation prevented cross-infection, with 2 studies showing that segregation decreased the cross-infection with Pseudomonas. With all these measures, there have been very impressive reductions in the prevalence of chronic Pseudomonas infection in children. In Leeds and in Belgium, studies have dropped prevalence from 23% to single figures, low single figures. Another pathogen was MRSA. This is this is the Madrid's report, that there was no segregation of these patients. They weren't treated unless they were hospitalized, no segregation unless hospitalized. And you can see from this, there's a trend to an increased prevalence of MRSA. But in this study, where there was segregation and there was aggressive treatment against MRSA, the incidence and prevalence remained low. Mycobacterium abscessus has been concerned of cross-infection with this. It is not inevitable. Many studies are saying, actually, when they look for treatment, cross-infection Mycobacterium abscessus, you don't find it, but there are a number of small studies where it could be potentially infectious. But we should also not just forget about the bacteria. We should also not forget about respiratory viruses. So vaccination, use of masks, standard prevention. When a patient comes up to a CF centre unwell, there's a good chance they've got an acute viral infection. We know that from our own studies during exacerbations, where many of the patients were positive for an acute virus. And therefore, patients coming up that day may be at increased risk if we let down our infection control. So how do we make it work? Well, for inpatients, ideally single rooms, ideally en suite, but also local infection control guidelines. We need to make sure we prevent contamination and cross-infection from equipment and rooms. And patients need their own equipment and delivery devices. Staff and patient education. For individual patients, they will need psychosocial support. Some may be concerned about coming up, concerned about cross-infection, but others may be concerned about the limitations that the infection control has placed upon them and may struggle with that. We need to make sure hand-washing facilities or gel are freely available at many areas of the inpatient ward. So we move a ward like this. We have moved from what was group activities for our CF adults, who were long-stay adults, with our social worker doing group activities, to individual patient activities. And for exercise, group exercises to individual exercise. So they can still carry on, but we need to adapt them. In outpatients, what can we do? Clinic flow. We can look at clinic flow. We can cohort clinics according to the infection status, still with individual isolation. We can schedule appointment times according to the number of rooms available and make sure not everyone comes up all at the same time and waits together. So keeping patient-to-patient contact to a minimum. At our centre, our patients will telephone with their mobile phones our administrator and our nurses to say they've arrived, and they will be brought up to the department one by one, and they will go into a room, and they will only leave that room when they're ready to go home, and we go into them all the time. All measurements are done in that room. We do their spirometry, we do their weight, We deliver the medication to the room by the pharmacist. They don't queue at pharmacy, and then they leave. And then the room is cleaned and the room is aired before the next patient. And again, staff and patient education is paramount to this. And we also educate our radiology department, so we don't have patients waiting in a queue for a chest x-ray or scan. And again, pharmacy, we bring the medication to the patient. We have a big adult centre, so we segregate by organisms, and we have to run, because of our patient numbers, clinics every day of the week. So we segregate but individually isolate within this. One of the challenges is the number of organisms that we encounter. When you look at them, they're vast. But underpinning it is always microbiological surveillance. So getting sputum sample from the patients, and then typing these sputum samples every now and again to make sure that we are not seeing a surge in infection with a CF pathogen. We know from studies that there are airborne dissemination of pathogens in cystic fibrosis, and these are higher at certain times, such as at wake-up and after physiotherapy. So we ensure that the bedroom has been cleaned and that the bedroom door is closed at all these times. We know from other studies that patients with CF can cough and disseminate organisms to room air. This is a cough sampling rib. And these are individual patients. And this is how far the patient would disseminate the organism. It's variable, and it varies from patient to patient, as does the time the organism stays in the air. But it does fall, and there's no difference between epidemic and non-epidemic strains. So we need to bear that in mind and try to keep our patients separate, if we can, from each other. But we also know that the face masks from the Australian study decreased the amount of Pseudomonas in these cough rigs and in the air. And these are adopted in many CF centres now as one of the means of infection control. But we also find that some patients don't want to be stigmatised by their cystic fibrosis with masks, so we need to educate and counsel and support those. What are the other potential measures? Well, there's other potential measures: UV radiation, mechanical ventilation of facilities, and HEPA filters. But telemedicine and home monitoring, of course, are a means as well of delivering care without patients having to come up. But we must make sure we see our patients. We insist that we see our patients at least once a year. And although we do some telemedicine appointments for our adults, we tend to alternate it between face-to-face appointments. What about the environment? We should bear that in mind too. We tell our adults that they can ride horses, but they shouldn't be mucking out the horses. Someone else should do that because of the risk of aspergillus. We do tell them to avoid jacuzzis. But we also tell them they must go out, they must exercise, they must have fulfillment in their lives. So we try to encourage them. Pet ownership is fine. Swimming in well-maintained pools is fine. Swimming in the sea is fine. Go out in the country. Live your life, and with your increased health status, go out and enjoy. But we also bear in mind career decisions as well. There are certain careers in healthcare for people with cystic fibrosis, that puts people at greater risk of acquisition of pathogens. So we need to counsel our patients at a very early age that they will be putting themselves in that risk, so they can make an informed decision about their career. But this again is changing, and again the adult physicians are learning from the pediatricians. These are the number of patients, the number of sputum samples from our patients over 4 years. And you can see the last two bars there after the onset of CFTR modulators, triple therapy. The number of sputum samples we're receiving is a lot less. So we're now getting patients who come up, we're struggling to bring up sputum. Cough rate experiments say actually, if you don't cough up much sputum, you're less likely to pick it up in the air. But screening and knowing which infection they have is becoming increasingly challenging for us. So in summary, infection control have reduced cross-infection in CF centres, but at a cost. We've lost holiday camps, and individuals have been particularly affected. Cross-infection risk is influenced by many factors: the pathogen, the strain, the mode of spread, and the environment. But accumulated evidence over the decades has meant infection control guidelines have evolved and will continue to evolve, but have been successful when they're applied in CF centres of preventing cross-infection. But to make it a success, you need close liaison between the CF multidisciplinary team, microbiology and infection disease at your local institution. And that should be encouraged. And when we build or create new centres, we should bear in mind infection control in the design too. Thank you very much. So now I'm going to tell you about the challenges we've had in our centre about responding to those increased patient numbers in our region. So I've already mentioned, and give you a little bit insight from the first talk about how our centre has evolved and changed over the years. And we've seen this slide before a couple of times. This is happening in the UK, it's happening throughout many countries with this median percentage survival age of the CF population. A brighter outlook for people with cystic fibrosis. And again, the numbers of children and adults, the children relatively static, but the number of adults increasing now, year upon year upon year. And this was the growth of our centre. The yellow bars are the number of referrals coming in, pretty straight line. The green section are those who were transferred out to have gone to live at other areas of the country. And the orange bar at the top of those who have sadly passed away. But if you combine the green and orange, the trajectory there is much lower than the trajectory of that yellow bar. So every year we're getting bigger. And with the advent of multidisciplinary care, all the therapies and modulators, that orange bar is starting to tail off significantly. So, the yellow bar isn't. So the number of adults is increasing exponentially and was in our centre. Our centre, as I mentioned earlier, was established with 19 adults in 1982 in a small centre with very few staff, very few facilities in an area north of Manchester. And it was part of an infectious disease unit at the time. But it grew. And once the centre was established, it started to grow. Expertise started to develop. A multidisciplinary team started to develop. To such that actually the patient population grew and grew. And in 1994, we moved to this centre. We were fortunate enough to get a grant from a charitable foundation to help build this centre. And we built a purpose-built facility. But our team grew and grew, and our patient numbers grew and grew. So in 2013, we extended the facility. You could see on that last picture there, the bigger building is our original facility, but it has been expanded downward to the road and outward to our corridor. And we have taken up all the available room in our hospital to do that. But still, we were facing more and more patients. And our team was getting bigger. This is the area of the northwest of England where we receive our patients. And you could see in the centre, this is where Manchester is. But our patients are received from all around the region. And you can see, perhaps near the coast, that there are quite a few patients. The larger circles denote the number of patients in that postcode. And there are quite a few patients in the north of our region. And they were travelling considerable travelling time, some distance, but travelling time because of the roads in the northwest of England to come to our centre. And they were increasing in numbers, as were our centre. So we had in our region 2 specialist CF centres in Manchester and in Liverpool. In paediatrics, it was a hub and spoke model. But we started lobbying for new regional services to provide more local care, but more importantly, not local care, but because of the expanding number of patients, to develop maybe a centre in the north of our region as well. And we looked at various options. Expanding our service, which we did, an independent centre or a hub and spoke or an outreach, and we blended these to try to create another centre because we thought we could not do nothing. But where'd you start? So in the UK, there were no entirely new centres at that time, apart from some in Scotland and Northern Ireland. There was no roadmap for us to how to really do this, and there were big challenges. But we got agreement from our regional commissioners to undertake this. And in fact, they gave us a pump prime in funding to try to develop another centre. And the UKCF Trust gave us a grant to train consultants in cystic fibrosis. And on that map is where the hospital is in Manchester on the bottom, and where the hospital is in Blackpool, where we started to develop another centre. And Starbucks is in the middle because that's where we actually started to meet consultants from Blackburn. We would drive halfway, we would meet them at Starbucks, and we would plan how we are going to develop care in that part of the region. But we were insistent that the care met service specifications, including staffing. The service had to be able to provide for urgent care needs. We weren't going to create a centre with decreased quality of care. We wanted a centre with similar standards of care. And how we did this for advice, 24 hours a day, 7 days a week. We wanted a specialist MDT. And the MDT had to be trained in cystic fibrosis with staffing levels appropriate to the size of the patient population, including study for annual leave, study leave, and long-term absence. So we looked at our patient population and how we could recruit them. And we knew in cystic fibrosis how many patients were under paediatric care, so how many in that region would be coming to an adult centre if one was there each year. And we looked at our own population. We had 75 patients living in that. And we asked them if there was a centre, would they want to move there? And we decided as well whether that might be appropriate, depending on their stage and their acuity of cystic fibrosis, their severity. And that allowed us to predict the numbers, it allowed us to predict income and the budget for this project. And we developed what was an extended mentorship model. So Blackpool was affiliated with Manchester and has remained so until Blackpool can become independent, which may happen one day, but hasn't happened so far. The consultants and team at Blackpool held honorary contracts at our hospital. We held honorary contracts at their hospital. They were very much part of our team. To begin with, the consultants at Blackpool attended our clinic and started looking after patients at our centre to build relationships with them, particularly those who lived in the north of the region. And they came every week. So we could train them and they could also see the patients who might one day be under their care. We did the same for all the multidisciplinary team. And we had regular outreach every 8 weeks from Manchester. We used to go to Blackpool. And that was in terms of governance and clinical care to help them develop and to make sure the patients who were there were having high quality care and were safe. We decided that we would do inpatient and outpatients from the very start. But all the new referrals to the Blackpool unit were screened by the Blackpool consultant and one of our consultants for suitability to be placed in this new centre to begin with. For on-call, out of hours, it's commutable, but we provided backup as well because there were only a limited number of staff at Blackpool. And the Commissioner's funding for Blackpool was channeled via our centre, so we could control the funding and make sure Blackpool was financially viable as it developed. For recruitment and training, there was assistance with job descriptions and interviewing. There was a named mentor at each site, and individualised training at our site. But we also shared standards of care, we shared governance, we shared protocols. So we had a mentorship arrangement, as the ECSF has tried with the Twinning project to have mentorship arrangement too with other centres. And today Blackpool has 60 patients. They have still ongoing governance and support from us. We have monthly meetings with our consultants, but we do it online. Their team has meetings with our team from various disciplines. And 3 times a year, we meet up for a face-to-face meeting, and we're meeting next week as well, where we go through figures, we go through governance, infection, any clinical events, but we also go through education. So we provide still ongoing education and support to that centre and mentorship as it still develops. And we've got nearly 400, well, we've got over 480 patients at Manchester now. But it's a very different population we have. We have an older population with more severe disease because the Blackwell Centre has taken transition patients. But we look after those too. So we have a very close working relationship and mentorship with this centre, which has been incredibly successful in developing but creating quality of care with an MDT approach at another centre. We also have independency with other specialities. Some of these specialities are present in Blackpool. We've helped train those, as well as the Blackpool team training those as well. But in addition, there are specialities that actually, if a patient has a problem, still come to our centre. So interventional radiology would be one example. And at present, if patients need exercise tests, they come to our centre. We have kept that close working relationship with the centre. But there have been huge changes in CF delivery over the last 5 years. Ongoing evolution of care, such as digital technology. Now, we have home spirometry. Patients can weigh themselves at home, perform oximetry and home diabetes monitoring. Postal sputums, postal bloods have emerged in our region, so we can monitor people. So the pressures at our centre in terms of facilities have changed, but we still need a team to care for these patients. But this has enabled development at our centre. For example, for patients who are treated on home intravenous antibiotics now, we replicate as much as possible what happens to them if they were treated as inpatients. They have an MDT, weekly or twice weekly, like our inpatients do. Our nurses will go out to them, but they will post in their spirometry. We will know what's happening with their weight. We will know what's happening with their blood tests. We will know what's happening with their diabetes control. So even the patients who are not in hospital, we try to create still that multidisciplinary team care to ensure if they have an exacerbation, they're not lost, but they have close follow-up and they will have maximized the chances of recovering from that exacerbation. And this technology is enabling us to do this. And there are also changes with new therapies. These are our outpatient contacts at our centre. And this is a graph here from the beginning of the COVID pandemic. We did very little video or telephone calls before. Now we just do telephone calls. But at the beginning of the COVID pandemic, we had to deliver care. So we moved to telephone and then to video calls. And that's the turquoise bar at the top, midway. The overall contacts is the top bar. The next bar, video calls, and after that, face-to-face appointments. And you can see patients coming back to us for face-to-face appointments after the COVID pandemic. And now, we still have video appointments for some of our patients. We probably have 2/3 of our appointments which are face-to-face and 1/3 which are video. But that has evolved in our unit as well. Our number of inpatient admissions has decreased. They've gone down dramatically, but the majority are still coming in with pulmonary exacerbations. That brings changes, it brings challenges. So when young people come to our centre, we see them less often. They're less likely to be admitted. It takes longer to build up the relationship. So we have invested more in transition. We were already doing transition, but we have funded a nurse fully for transition virtually now, as well as the rest of our team. And we build a lot of close relationships with our patients in transition. As I mentioned earlier, CF is evolving. I showed you this earlier, how our own population over the last 30 years has changed dramatically from being adolescents to now being older adults above the age of 30 predominantly. And we know from studies that extrapulmonary complications increase with age. So we're having to adapt, not just the centre, in terms of the building, but as a team to these demands to make sure that we deliver high quality care for our patients now and the future, bearing in mind the projections, in a condition we're still learning about. And as I mentioned, we need to think about evolving and adapting, but the core of it still remains the CFMDT, which is essential, the CF care. So the population itself is growing in numbers and is evolving, and clinical care is evolving. There will be many solutions and challenges, and they will depend on locality. So there is an increasing population of older adults, but it will be, the solutions are probably bespoke by region, bespoke by funding, but we should not neglect the ongoing need and the advantages of CF multidisciplinary care. And we can use experienced CF multidisciplinary teams to support those who are in evolution. We have done it locally to develop a unit, and we look forward to the future where we are now linked with a unit from Slovakia. So this is our team. Now it's a much bigger team than when we started in 1982 in that Nissen hut. And we have nearly 500 adults. Things are brighter for our adult population than they were. But we do need a multidisciplinary team. So thank you for your attention.
Professor Andrew M. Jones, thank you so much. Hold on for a second. Doamnelor, domnilor, stimați invitați, domnul profesor Jones are avion undeva la și 10 minute, la și un sfert ar trebui să plece. Însă l-am rugat frumos să acorde...
15 minutes, so if you have questions, he will be here.
Just a second. Imediat să-i dăm o pereche de căști, că nu are. Le are? Mulțumesc frumos.
Okay, good to go.
Yes.
Vorbeați în prezentarea dumneavoastră despre eradicarea infecției cu
the eradication of Pseudomonas infections. If you'll allow me to be a bit subjective, I will ask you the following. If we've had a first infection at 1.5-year-old and then a reinfection at 3 years old, for 3 years now, we've sterilized everything, but can we speak of an eradication of the infection now? Thank you.
Aggressively and goes away, and another infection ensues because people with cystic fibrosis are predisposed to picking up Pseudomonas, which will be in the environment. In studies, in most cases, this is a new strain. This is a new infection. Although there are challenges now because you have to be able to adequately sample to actually see if Pseudomonas is still there. That is a challenge. I'm not a pediatrician, and it's a great challenge, I recognize, in very young children. But it is also a challenge in adults now. But the key to this is microbiological sampling. Some patients will still have progressed to chronic infection, but we can delay that often by treating, but we will only be able to treat if we know it's there. So the importance in eradication strategies is having a good microbiological service, sending samples and having good communication. So at our centre, our microbiologist, if there's a Pseudomonas growth in a patient who is not classified as having Pseudomonas, they will have it on their database. We share the database with them. And as soon as that growth happens, they send us an email to our entire team saying there is Pseudomonas in this patient, where they're not expecting Pseudomonas. So we can be alert, we can call that patient back, and we can treat promptly.
Categoric, probele sunt recoltate periodic. Este posibil ca
regularly. Is it possible in a longer period of time for the infection not to crop up in the microbiological testing? And is it important that Both times when Pseudomonas was identified, the patient was asymptomatic. Is it a good thing because the patient didn't reach exacerbation, or since the infection is there, it's irrelevant whether it's symptomatic or not?
Some of the growths of Pseudomonas will be in association with exacerbations, but some will not. But irrespective, it should be treated if it's a new growth to try to eradicate it. The challenge of getting good samples is shared between all adult and pediatric centres now. The limitations of being able to do what is called strain typing, to look at the fingerprint of the organism to see if it's the same strain, will vary from country to country and region to region. But we do know from studies that actually if you treat it aggressively, you can delay the onset. So most studies create the phrase delay the onset of Pseudomonas infection to a much later age, and hopefully therefore delay any damage from Pseudomonas in the lung. CFTR modulators, I think, are changing this space. So whether people are still as susceptible, we don't know. We must assume that they are at present. But we do know mucociliary clearance is enhanced with modulators. So there's a potential that we might see less acquisition, but we will still see it. We know that because we are still seeing it. But also, we are struggling to get sputum and lower respiratory tract samples for these patients. So strategies that evolving at our centre now, we undertake induced sputum at least once a year to screen for infection, while we're struggling to get patients to give us lower respiratory tract samples.
Dacă vorbim de pacienții de copii,
when it comes to small children who cannot expectorate, and we use every month I mean, if we have smaller children and we do the tests every month and then every 3 months, it should be a conclusive form. What do we do? How do you do microbiological testing in your center?
I only look after adults, so I don't look after the young children, and maybe a pediatrician, Mila? Might be. Tomorrow. You will come tomorrow, you will get the answer to that question.
E un subiect pentru mâine, acum ne referim la...
It's a topic for tomorrow, okay.
Revin la adulți.
Going back to adults now.
Odată cu introducerea
Once with
modulatoarelor,
introduction
toată
of
lumea
modulators, everyone knows that coughing disappears, that chronic cough disappears. So the cough goes away, the sputum becomes clear, and at some point there is no sputum at all. How do you go about in getting a good result? How do you sample?
For children, that's coming tomorrow, and that's probably going
Nu,
to
nu,
be
nu.
the answer that it's
Vorbesc de
going to
adulți. Adulți.
be. Okay, so we have now moved to doing cough swabs, but we also do induced sputum. So the patients come up in person. We have a physiotherapist. We are well staffed by physiotherapists, and the physiotherapist will work with the patient, and if necessary, do an induced sputum to get a sample. There is a study from Wales, from Cardiff, about the use, the SPIT study of the use of induced sputum to get lower airway sampling, which shows that actually with induced sputum you can get very good quality lower airway sampling, but you need the resources.
Okay. O altă întrebare. Ați spus
Referitor la întrebarea pe care ați spus-o dumneavoastră, cu aceeași situație ne întâlnim și
We face the same situation here in Romania in our adult centers. We recommend our patients to have an aerosol therapy with hypertonic serum before we take the sputum. And as the professor was saying, we have a physio and kinesiotherapy session to stimulate sputum. And our colleague Alexandru Grișan, who is a specialist in these procedures, can explain to you how this is done. Okay, then I have one more question, and that's it. You said that diabetes can be a side effect, side reaction to modulators. My question is, how did you sort this out? Was it through nutrition? Was it through the introduction of treatment?
That's just an example of how CF care is evolving. So what we see
Bănuiesc-
with diabetes is that
Bănuiesc că
actually
aveți
with
pacienți.
modulators, they have there's decreased systemic inflammation, which might be one of the factors that is stabilizing diabetes control. Studies show that HbA1c levels drop in patients on modulators, but actually studies also show that weight gain happens. So we work, or our dietitians specifically, work with our patients, but also our psychologist works with the patients to adapt changes in their lifestyle. This is very difficult for many of the patients who, for all their life, have been eating high-calorie, high-fat diets, trying to gain weight, but actually have gone on a trajectory where they are now overweight. It's a challenge in society as well for the normal population, as you know in Europe, but also for the CF patients specifically, changing behaviour can be difficult and challenging. But we monitor for diabetes at each annual assessment, and we have a CF diabetes nurses, specifically nurses who specialise in CF diabetes, who see our patients at review as well. And we have a local diabetologist consultant who comes to our centre, our clinic, and does clinics with our patients. So they have very close monitoring of their diabetes. The treatment is also, and management is also evolving. So now we have devices such as Freestyle Libre that can measure interstitial glucose that can provide monitoring. And now bionic pancreases that can liaise with the monitor and deliver insulin. So the pancreas is artificial but helps control patients. So this is an area I think that is evolving rapidly in cystic fibrosis diabetes, influenced by many factors.
O ultimă întrebare, vă rog, ultimă întrebare ca să lăsăm pe...
So that Professor Jones may catch his flight. Something specific for infection control in adults with CF. Do you have any questions related to this particular topic? Any comments? For the time being, I don't. All right, if there are no further questions, we would like to thank Professor Jones. Thank you for being here. May you have a safe flight back home, back to Manchester. Thank you for being here. Moving on now, I have two announcements before I invite the next speaker. We received a few questions from our guests online. They all refer to children. So, shall I ask these questions today or shall I ask them tomorrow? Anyway, we'll have a Q&A session where I will ask these questions coming from online. There's a slight change in the schedule because tomorrow many of our guests will have to catch their flights early. So we start at 9 o'clock instead of 9:30 tomorrow morning. Thank you for your understanding. We'd like to thank Professor Jones once again, and now we're moving on. We'll talk about the role of breathing exercises in managing anxiety in adult patients with CF. Mr. Alexandru Florian Crișan from Timișoara, welcome. You have the floor. Hello, my name is Crișan Alexandru. I'm a kinesiotherapist. I specialize in respiratory recovery, and I work at Babish Hospital in Timișoara. I will talk about the role of breathing exercises in managing anxiety in adult patients with CF. This is the incidence of patients with CF. There are roughly 1,000 new cases each year. What I'm interested in mostly is the fact that over 50% of these patients are over 18 years old. When it comes to prevalence, the prevalence is very high, between 30 and 80% with patients with CF. Moreover, anxiety is usually associated with a lack of adherence to treatment, to medical treatment, and to respiratory recovery. The results are much poorer, and anxiety can also exacerbate the respiratory symptoms in CF patients. This is a presentation from 2014. It shows us that the incidence of prevalence is 2 or 3 times bigger than in the larger population, and the most affected are the next of kin, the mother, the father of the patient, and then the adolescent or adult with CF. I'm using this slide because we come across such issues very often. Some CF patients are compliant when they are not accompanied by next of kin. This report, dating back to 2023, shows that over $7 billion have been invested in the management of mental health. Here are a few differences between stress and anxiety. Stress is a response to what we know and is a short-term response. However, anxiety can take a much longer time, and it is a response to something we cannot identify. It's a trigger we can't put our finger on. But we have some common symptoms: diarrhea, dyspnea, constipation, tachycardia as well. The impact of anxiety on the general health of a patient. Anxious patients have lower lung function, have more exacerbations, and have longer admissions in hospital. The Manual of Mental Disorder defines general anxiety, the presence of 3 symptoms out of the 6 symptoms you have here on the slide over the past 6 months. Honestly speaking, if I were to read all of them, fatigue, difficulty to focus, difficulty to sleep, I get the impression that we all suffer from anxiety. And there are 3 main components and reactions to anxiety. I will read them in reverse. First of all, we have the awareness that leads to tension and hypervigilance, and then we have a response, the physiological and physical response. That means the autonomous response kicks in. We can even get hyperventilation. When we speak about the assessing and treating of depression and anxiety, we speak about general anxiety. And if we have a score between 5 and 9, we need supportive intervention and multidisciplinary intervention. There are several theories saying how this panic attack happens. I will not mention all of them, but if there's a stress factor, the patient starts to hyperventilate. When the patient hyperventilates, the carbon dioxide is eliminated very fast, and it cannot get back in the body as
fast as it should, and we have this false suffocation alarm, which is characterized by dyspnea. We have this scheme. You can see here the stress. We have this sensation of lack of air, feelings of anxiety, until it becomes like somatization. So basically, something that didn't exist leads to chest tightness, muscle tension, hyperventilation. Moreover than that, the breathing exercises help in the anxiety management. We have the autonomic nervous system helping us to reach the sympathetic nervous system. Then, if we have the HRV increased, this can lead to a cardiovascular diseases. Just by deep breathing exercising, you can stimulate the vagus nerve, which slows the heart rate and it calms the body. This slide underlines that there are several breathing exercise methods and exercises. You can see on the top of the slide for the adults who are healthy, so you see the healthy adults, and this slide focuses on chronic patients, even for cancer patients. I tried to summarize the breathing exercises by 3 categories: diaphragmatic breathing, pursed lips breathing, and box breathing. This is diaphragmatic breathing. You can see in the lower part how the diaphragm is moving. And what's the most important thing to keep in mind is that we reduce the accessory muscles. Pursed lips breathing, it is one of the most used techniques because it prolongs the exhalation and it prevents the airway collapse and improves gas exchange. And the box breathing technique, this means there's an equal number of period of time dedicated to the inhale, apnea, and exhale, equal number of seconds. And I need to mention the active cycle of breathing techniques, especially for CF patients, where we have several cycles that keep repeating. We have the breath control, then the deep breathing. You see here a very nice drawing, and it's finalized by huffing and then coughing, and that's the order. Here you see a study of 58 studies, and with the red you can see what was not efficient, and in blue what was efficient. This review includes slow techniques, increased or regular. And you can see that the most efficient techniques are the slow techniques. The same review also had 72 interventions. I will not mention all of them because we don't have enough time. But it's important to keep in mind that these should not be quick breaths. The sessions should not last less than 5 minutes. And what we do want to emphasize is that this training needs to be guided by specialists. We have to have multiple sessions, and we want to include them long term. The technique per se shouldn't be interrupted. It shouldn't be done in a patient that prevents the diaphragm from moving, or it shouldn't have very complicated exercises. From the point of view of the research, we need more randomized studies showing the efficiency of such works. The guidelines are the following. I'm not going to read everything, but I emphasize that this should be performed in a comfortable position and in a nice environment. Breathing exercises should be used for several purposes. The main purpose being the active cycle for clearing the lungs and for removing the excess in the lungs, and also to try to reduce the level of anxiety for these patients. Thank you so much for your input. And now we move to psychosocial aspects of CF, and I invite Trudy Havermans from Belgium.
Thank you. Sorry for the delay. I was stuck in my headphones. Hello. Very nice to be here. I'm a clinical psychologist, Trudy. I work in CF for nearly 24 years now in Leuven. Don't know whether anybody has said, but Leuven is a center in Belgium, in a small town, and we have just over 100 pediatric patients, about 170 adult patients, and over 120 transplanted patients. So we are very lucky to have all these beautiful people to look after. And I work together as a full-time psychologist. We are very lucky. And then together with a younger psychologist who looks after the children together with me. So we are very lucky. And I know this is not always the case in Romania or other Eastern European countries. So I'm just, through my talk, I would just like to inspire you what is possible, and then you can feel and you can think about what is possible for you and for your patients. So psychological issues. Today I'm going to talk about, of course, holistic care in CF and the lifespan, diagnosis, primary school, adolescence, adult age, transplantation. I've got 20 minutes, which is very, very little. I could talk about this for 3 days. And then some special topics in between, adherence and mental health. So what is holistic care? You've got the patient, the person with cystic fibrosis, the team and the family. They're in the core. What they need, if we're looking at psychosocial care, holistic care, is social support. It depends on their cognitive abilities. There is an interrelation with mental health, with society, for example, financial reimbursements. But there's also it's determined by the illness characteristics. How ill is a person? What are the symptoms? What are the problems he or she is facing? And now we have the CFTR modulators, and all these aspects you can see there is so many sub-aspects. So it's like a huge circle surrounding this patient, the family, the CF team, and all of these aspects we have to deal and cover with. So, you may think like a full-time psychologist for 380 patients is a lot, but if you see all the things that we are trying to support patients and families with, it's really not that much. And then there's good luck and bad luck. Because all these issues are also important in your country, but you may not be as lucky to have the support that you really should have. But also bad luck, for example, if someone has got the wrong genotype, so they can't have certain modulator therapy which is available at the moment. So there is a lot of things to talk about when we're talking about holistic care. Now, lifespan support, in the 1950s, the life expectancy was 2 years, and as we see over time, it goes up. When I started working in CF, it was about 30, 32 years, but I must say that the average age at death was around 20, so I'm sad to say that we've kind of lost quite a lot of patients as well over the years. But life expectancy is going up, and it's continuing to go up. They're now talking about over 66 years that the children are being born today. This is hopeful. So what happens at diagnosis if we look at it from a psychosocial perspective? There is a difference, and we've heard that over the last couple of days, differences in traditional diagnosis and the neonatal screening. When very often parents, they have a healthy baby, and it's very hard to believe that there's something wrong with this child. Or when the traditional, without neonatal screening, there is something really wrong with your child. So this early start at diagnosis is different. So it's important to think of that context. Good communication from the start. And parents may need support in creating a balance between the intrusion of CF and the treatment, everything that's happening, they need to learn so much. The impact on the family, your whole family life is kind of broken. All your family, your dreams about your family are shattered by the diagnosis. And the involvement of this CF team, all of a sudden, if we look at our team, there are about 14 people, standing around this little baby, and all of a sudden the parents may feel there's all these people interfering with their child. If we think about what Cindy, our nurse, has said this morning, in the early days, the first say 6 months after diagnosis, Cindy will phone new parents every week or every 2 weeks, depending on what they need. So there's a very close contact. It's very important in the early days. That's where education and information starts. And as a psychologist, we start to observe, and we start to interact with people, because psychoeducation is important. Psychoeducation is why do I feel the way I feel? Talking about that, trying to understand why am I feeling the way I am feeling. Psychosocial support, help with coping. What are good coping styles? What are maybe not so good coping styles? And again, why do I cope this way? This can be because, if you think about families, this is because my mother or my father always coped with illness like that. So we need to understand why we do the things what we do. And of course, at diagnosis, this is a little baby. Early attachment is very important. So as a psychologist, we try to follow up on that and support parents. Now, what are the first 5 years? If we look at our little children, what are key themes? Attachment, the bond between parents and their child, language development. All these children are healthy, also healthy children. They may have cystic fibrosis, but they also have a healthy development. They need to learn to talk. They need to learn to crawl and to walk. They need their social, emotional development, maybe with their brothers or sisters. They need to play. They need to start to understand rules. And for example, if we look at the first couple of years, they need to, toilet training is part of normal daily life, not only cystic fibrosis. But when we look at cystic fibrosis, in these early years. There is the symptoms, there may be the pain, it's definitely the start of the treatment, there may be invasive procedures on these little children, there's hospitalization, and there's the CF team, as I said before. So the normal developmental tasks, nice things, beautiful things, play, will development, we all know the terrible twos. Also, children with cystic fibrosis can be terrible twos, if you know what I mean. They can throw themselves on the floor and say, I don't want to cooperate. There is nothing wrong with that child. That's perfectly normal from a developmental point of view. But of course, it's not very handy if the doctor's waiting or the nurse is waiting and they want to do lots of things. So how do we help parents with absolutely normal things? What we need in the first couple of years post-diagnosis is we need time, plenty of time to get to know one another and to come to terms with the diagnosis. For the parents, this is a really heartbreaking time. So what happens in the era of modulators? Because that's slightly different. Still, the disease for many young parents, they've never heard of CF, but the prospect of modulator therapy, that kind of may console them, that may give them a little bit more hope than we saw in the days before Kaftrio. Personal risk, if you see left at the bottom, my child will stay well, I'm confident, make them feel confident. So this is why I'm saying what part of the role of the psychologist is to talk and discuss these kind of things, psychoeducate parents, young parents in this area of modulator treatment. It's quite different than before the modulators. Primary school age, what are the key themes there? They go to school, they have to try and learn social skills, free play, education, but also discipline. They have to sit still all day, and they become a little bit more independent. But cystic fibrosis is still an intrusive part of their life with, the therapy they have to do, but also meal times. They have to eat these high caloric foods. This may not be easy. And there is this first awareness during primary school that they are different, because you may know a child that asks another child, when are you doing your nebulizer treatment? And then they find out, oh, I'm the only one who's doing that, so feeling slightly different. This is being a normal child in a normal development, but having something special. Adolescents' key themes. Don't know. May I ask, do we have parents of adolescents in the room? One. You may recognize this, you may not, but we may have physicians or healthcare providers who have adolescents at home. Because really, what do adolescents do? They are, trying to form their identity. They are concerned about their body image. If we all think, because we are all adults here, but we've all had that, we are exactly the same as our patients. Yeah? We are experimenting. We should not, maybe, but we are. They do. They experiment with maybe smoking, with drugs. And of course, we do not want them to do this, but they are, as I said, normal developmental people. They go to school and they dream about a future. Having CF sometimes may make this a little bit more difficult, because they realize, as they started realizing during primary school, that they are different. Maybe they feel abnormal. I hope not, but they may become rebellious, defiant. That is something that we see a little bit more during adolescence. They may be a little bit more anxious or maybe depressed. They may pretend nothing's wrong. The really boisterous young boys or girls. How about disclosing cystic fibrosis to your friends? Are you telling them or are you not telling them? And there is often this is often the period also of new diagnosis, so something else to come to terms with. Sometimes deterioration starting during adolescence. And of course, adherence becomes more and more important as we are gradually preparing them for adult life. There comes a time when they have to become more responsible themselves and fully responsible, and we call this self-management. That's part of what psychosocial care is all about. So psychological processes in the era of modulator treatment for these children and these adolescents. When they've got cystic fibrosis-related diabetes, I hate it, I do not want it. That's what I'm hearing in the clinic. These are quotes from the clinic. I will try to join the police force. Until now, I could not, but maybe with this modulator treatment, they will allow me to join the police force. Kaftio is good, but my mood is not. I have changed. Another person may say, my life is great since Kaftio. It's absolutely wonderful. So, you know, it's very important that we listen to our youngsters. What is important to them? Oh, what's this? Oh. There's something on my screen. There's nothing on your screen. Pitfalls. I'm back. What are the pitfalls, some of the pitfalls during childhood and adolescence? Overprotection. Now, as a psychologist, I always say when our physicians are saying, oh, they're far too careful, they're overprotecting their child. I tend to reply, you cannot overprotect a child. You know, this is a child, it needs protection. What is a slight danger is that you protect your child so carefully that he cannot or she cannot develop. You know? So overprotection is not a problem. It is not allowing your child to develop. That may be a problem. There's eating problems, we all know. There is sleeping problems, behavioral problems. We know, in the hospital, when there's, for example, with blood taking, we can have real anxious children that can become really, really naughty, and for all good reasons, because I think they should protect themselves, but on the other hand, of course, this is part of their life. They need to come to terms with the fact that that's what their life's about, and they need to learn, and we need to support and help them. Parental anxiety and depression. The previous speaker has talked a little bit about anxiety and depression, but we know that when a child's parents have anxiety or depressive problems, then this may be a threat to attachment. Now, I'm saying this, but at the same time adding that this also counts for healthy parents and healthy children. When a healthy child has a parent who's got problems with anxiety or depression, there's also problems with attachment. So we have to be very careful that we do not forget that, in fact, our children, or your children, I should say, our patients, are normally developing individuals. But they have cystic fibrosis, which sometimes makes it slightly more difficult. So I have to say, because I really believe this, and I've seen this in all these years, that over time, the majority of the young people with cystic fibrosis do incredibly well, and I hope you recognize that from your own children as well. Not everything, but many, many aspects of their day-to-day development, their lives, their early lives, they're doing really well. So the adults, because I suddenly realized that I was in the session of adults. I do apologize, but all the adults have been children, and we cannot forget where they come from. So also the adult physician in this room, or the adult patient in this room, you are the adult because you were once that particular child or that particular adolescent. Yeah? You're in development. So what's important with adults? What's important for us, adults? Work, relationship, friendships, family, maybe buying a house, becoming independent, being independent, and having some fulfillment. I do hope that all of you in the room think, yes, these are very important key themes of my life. But if you have cystic fibrosis, this may become a little bit more challenging. Yeah? If you just think about one of the conferences, they focused on a sexual relationship, intimate relationship. Just think about your first kiss. You all think back to your first kiss, if you can remember. Everybody's got it in their head. Can you imagine, just before that, you were thinking, I hope I'm not going to cough. Yeah? So having intimate relationships with cystic fibrosis, when you are, sputum producing, because if not, of course, that's not a problem, this is slightly different. So this is just one part. I talk to adult patients, and there is so many different topics. I cannot. I mean, as I said, I could talk whole day if I really wanted to. Reproductive and sexual health becomes a topic. And luckily with Kaftrio, this is possible. More and more men and women with cystic fibrosis can plan to have and to make a family. But there is an uncertain future, even with Kaftrio, I think. There may become more symptoms. They feel they have a lack of time. That is what maybe, I'm not sure whether that comes later on, but in the era of modulators, I feel the patients say, the adult patients say, I feel I've got more time. And they can breathe and relax. I have got time. I don't have to do all my plans in the next 10 years because I may have a little bit more time. Adherence is a problem or is an issue. Independence and the prospect of transplantation. Luckily with modulated treatment, this has really reduced the incidence of transplantation in our clinic. So let's hope it stays that way. So looking at this psychological process, one patient asked me, do I still have CF, this so-called fatal disease I was born with after? No, now I'm taking Kaftrio. Consequences, our adult physician from Manchester, he left, but he didn't talk about menopause. We have several adult women going through menopause. And, menopause is, for all the women who are going through menopause, it's quite interesting, but I had never thought I would talk to my patients about the menopause. So it's something new. Kaftrio, my head is struggling to understand what's happening, but I'm really happy, but I'm also confused. These are the things adult patients communicate to me. So. And then there is a talk about transplantation later, but end of life and transplantation, that's the next step after adulthood, although luckily our adults are going to be much older. It's an emotional roller coaster. The choosing, do I want to have a transplantation, yes or not? I know this is probably, maybe in your country, not even an option. I'm not sure. I should have asked, but I haven't. But in our clinic, it is an option. But even then, people, some may decide that they do not want this. Then they have to wait if they decide to. They have to cope with deterioration. They have got lots and lots of information about it. And they need a lot of tender, loving care. Now, the decision to transplant, sometimes there is a decision not to transplant, and then we're talking about pain management, sometimes euthanasia, which is possible in Belgium. A palliative support team needs to be involved, and we need to talk about quality of end of life, not just quality of life. When we do go for transplantation, adherence becomes very important, even though it's very, very difficult. Caring for the family, but also there's a worry about the donor. Patients think about that. So a family is going to lose a person because I want to live. And then, of course, anxiety about what's to come, but also anxiety to maybe die whilst on the waiting list. Advanced care planning, very important. So now my special topics. I hope I'm not going over time. I don't really know. I don't think so. Treatment adherence. Some of the talks have already alluded to this. Is it deliberate? Is it unwilling? Is it simply forgetting? It's very hard to measure. We don't really know how to measure adherence. But the consequences are great. Costs, symptoms. If your doctor prescribes you a certain medicine, the patient doesn't take it, the doctor may say, oh, you need to take another one, and you need to take another one, but they're not taking the medication. And it all depends a little bit like what do they feel about this therapy? How do they experience it? For example, just the taste is awful, I'm not doing this nebulizer. Yeah? These are important things that we need to talk and take into account. Patients make their own decisions. We often forget this, but they do. And it's really not about us to judge this. Yeah? What are important barriers for adherence? Time. Simple as that. All of you imagine you have to do 1 hour of physiotherapy every day, do your nebulizers, and make some extra food because you have to eat 6 meals a day. Just imagine, this would probably take you about 2 hours on your already very busy schedule. Forgetting, motivation, and not wanting to be different. I have seen young people not wanting to take their crayon because they did not want their friends to know. Yeah? What are predictors of adherence? Now, all the healthcare professionals, listen carefully. Psychological, emotional, family and social support, feelings of control. I'm in control of my illness and of my treatment. But one of the most predictive predictors of adherence, the most strong predictor of adherence, is the empathy of the physician. Bless you. So what can we do? Do not judge. Please do not judge. Listen to your patient and try to find a solution for how to best go ahead. So, make an achievable goal together. And sometimes we can use cognitive behavioral therapy, motivational interviewing, social support, for example, role models or social media. And psychoeducation is, again, why do I do or why do I feel the way I do, the way I feel? It's very important. Technology-based intervention, texting, email, we've heard these things before. My second special topic, mental health. Now, if patients exhibit psychological distress, they are more likely to experience a range of adverse effects. Poorer adherence, lower pulmonary function, more frequent hospitalization, increased healthcare costs, and quality of life, of course. They all seem so obvious. Of course, if you don't feel well, these are the things that are happening. This also happens to healthy people. Let me remind you, our patients are not different from ourselves. So what is depression? The previous speaker already talked a little bit about it. It's a state of low mood. It's an aversion to activity, and it affects your thoughts. Symptoms are sadness, inactivity, lack of appetite, things we remember, we know. Anxiety is an unpleasant state of an inner turmoil. We all know the feeling of anxiety. And symptoms are restlessness, fatigue, and there is all sorts of different types of anxiety. Now, it's very important if we talk about cystic fibrosis because the numbers that were given in the epidemiological study, they were really quite high. I strongly believe that they are lower. Our patients' depression is slightly more depressed than the healthy population. Anxiety, however, I think our patients are slightly more anxious than the healthy population. But they're not really that different. With good support, it doesn't have to be that different. I really strongly believe that. How to recognize? This is what you can look at in your clinic or at home with your little children. If they are always asking, why me, I feel different, or the children who withdraw to their rooms, not if they're adolescents, because that would be normal. Always think about the context. Absence from school, or work, overprotection, attention-seeking, non-adherence, then you may think, maybe my child, or maybe my brother, sister, father, maybe has depressive feelings or feels anxious for whatever reason. And I do believe that in our society, we do not ask enough, how are you feeling? How are you really feeling? And especially when it's your loved ones at home, you should really ask, how are you? And then be open for any answer, even if it's not the most, if this is the answer, I'm feeling really bad. What are you going to do? Listen. Mental health screening, very important, very good paper, I'm just referring to that. But it's very, very complicated, mental health screening. It's not as easy, it's not just registering a questionnaire. You need to follow up and you need to have a plan afterwards. Now, mental health in the era of modulators, depressive symptoms have been reported: insomnia, brain fog, anxiety, irritability, and the epidemiology doesn't seem to be that much different from before modulator therapy, some of the recent papers. At a population level, there is no worsening in symptoms of depression. It is more anxiety. As I said before, anxiety is probably more of a problem than depression. And maybe, one of the papers said, the depression after Kaftrio is like a starting phenomenon because so many different things change in life. So maybe it's a temporary thing. Anxiety does not seem to change. And in the clinic, even though they have not been reported in the studies, we do see it, so we cannot ignore it. But is it a direct or an indirect consequence of Kaftrio? Don't really know. Screening is important. We need to follow it up and make sure that we've got data. Oh, and we need to follow up long term. But maybe, and I'm convinced about it, we need the dust to settle. Let us give us some time to get used to this new medication and see what happens, also from a mental point of view. Many questions remain. What else? I'm nearly there. Psychosocial carers, psychologists, we need to support a person's social support system. Grandparents, why not? A very involved grandmother or a very involved grandfather, they're important. But there's also financial and social implications. There is the longer-term adjustment of identity, goals, existential ideas. We need to follow that up. We don't know where we're going, but psychosocial topics are related to these topics. There is going to be a new generation of patients with new adjustments and also new psychosocial care. I'm very curious. I really hope for I'm going to work for another 7 years. I'm really curious what's going to happen to our patients and to their lives. But also, the modulators, for example, they have an impact on us, on us as healthcare professionals, because we don't really know this. We are a little bit insecure what's happening in the future, what's happening to our patients. The standards of care, beautifully reviewed by Elke, but in there is also the importance of psychosocial healthcare professionals as a fundamental part of the CF team. We should be there. So we have old problems and we have new problems. And adjustment is a psychological process for healthy people and for people with cystic fibrosis. There is really not a difference. Personalized care is crucial. Look at your individual patient and listen. If anything you remember from my talk is, when you go home, you say, oh, what was this psychologist talking about? Aha, I have to listen to my patient and to my parents. And we need to be patient because we don't know what's coming. We need to be patient for ourselves and for our patients. Thank you.
Thank you, Trudy Havermans. Mulțumim frumos, thank you. Repede ca să recuperăm un pic din timp, o invit
And now I would like to give the floor to Camelia Pescaru, coming from Timișoara, speaking about the situation of adult CF care in Romania. Hello, and thank you for inviting me. I will be speaking about several aspects regarding the CF Adult Center in Timișoara. This is also, I want to also thank Cristian Oancea for helping me. As you know, in 1938, the life expectancy was very low, and now it is up to 58. It's also important to speak about the sweat test. We know that there are so many treatments, aerosol treatment that were very helpful, And modulators are present in Romania have been present for 2 years. We thank our patients and we thank Mihaița for his hard work in bringing modulators in Romania. We already know that this is a multiple organ disease. It starts with the lung, but it affects so many organs, so we need a multidisciplinary team for a multidisciplinary approach. I am lucky enough to work in a center where we have all the necessary experts, including physiotherapist and kinesiotherapist, especially for adults. So if you have questions, please don't hesitate to ask at the end of my presentation. A multidisciplinary approach is extremely important, and it also must be customized. We have here several data that were available before the registry was closed. We have almost 500 patients, out of which 312 are children and 180 are patients. There are more men than women, and the mean age of diagnosis was 3.9, 19 years old, and we also have late diagnosis. We have 4 patients that were diagnosed as children, and we must pay attention to their care because they have a lot of bronchial ecstasies, and we need to test them also for cystic fibrosis. As I said, average life expectancy keeps increasing. Luckily, some of our patients are students. We have a girl who graduated from medical school. She also got married this year, and she wants to have children. She works in a medical lab now. Unfortunately, we also had patients that we lost, 66 patients, but we hope for this number to decrease. And we have, with rare diseases, 454 children per year. These are the centers in Romania dealing with adult care. Some of them also treat children. As Professor Maciek said this morning, we have a great collaboration with him through the grant from the European Registry, and we can send them samples for genetic sampling and sequencing. The newborn screening has been introduced in Romania 2 years ago, and it helps us a lot. Let's not forget that this is not a diagnosis. It just identifies the increased risk and facilitates the early diagnosis. Romania is indicated here with that arrow. We introduced all the adult patients in this register. The proportion of adults with CIF varies considerably between European countries. The prevalence of the variant F508 You can see it here, and it's important to know it because we have to customize the treatment. We have several information about the distribution by age and sex groups cared for in Institute Marius Nasta. We see that we have respiratory problems. The lung function decreases with age, but seeing the modulators, we see that this the lung function improves. From the point of view of bacteria, this is valid. The respiratory infections, you can see an increase, and it is more frequent. The staphylococcus is more frequent for younger patients. From the point of view of germs, we see here the most frequent ones. In our hospital, after introducing this data, you can see here the gender distribution. Both the male and female patients are affected. Regarding the year of diagnosis, we have infections more for children who are around 8. Our last case was a patient of 35 years old who was diagnosed in our hospital, and she has a very good evolution. The lung function, I told you, decreases with age, but the modulators therapy and respiratory therapies improve it. Pseudomonas aeruginosa is present for all age groups, but we do apply antibiotics, and Staphylococcus aureus is present in younger population. We have also case of allergic bronchopulmonary infections. We also have a diabetes specialist in our hospital helping us with the complications for CF patients. And from the point of view of liver disease, you see here their incidence. We have only one patient who benefited of long-term oxygen therapy, and he's doing quite well. We are happy about it. Generally speaking, he's doing well. From the point of view of management strategies for the patients, their therapy with modulators is extremely important, but their outpatient treatment is very important. It is important to take into consideration a good nutrition, the supplements, the fat-soluble vitamins, of course, implementation of infection control measures, vaccination against the flu, and the treatment of metabolic and other type of complications.
Modulators have led to an improvement in lung function and nutritional status, a reduction of hospitalizations and exacerbations over the past 6 months. No patient had exacerbations, so there was no need to admit them to hospital. We have strong points, newborn screening, modulator therapy. Our patients benefit from respiratory rehabilitation. We have a dedicated team. As weak points, the genetic tests are not reimbursed, but as you saw, they can send them to Professor Bachu whenever needed. We don't have a sweat test device. We can report to the European registry, and we have an association of patient support, and there is a lack of funding. There are many challenges in the lives of patients with CF, and for us as specialists, we try to manage them as best we can. We need ever more centers for adults because the adult patients will be more numerous. And we have a national guide. We're working on a national guide for adults with CF. Here is the transition period. This is the moment when patients move from the pediatric session to our center. We are able to welcome them, to manage their problems, and to increase the quality of life of these patients, to reduce exacerbations, and to give them, to offer them individualized management. Thank you very much. If there are any questions, I'm here to answer them. If there are no questions, as a moderator, I would like to ask my colleague, Alexandru Crișan, to briefly tell you about the benefits of respiratory rehabilitation in patients that benefit from custom-made programs for CF. Just very briefly. All articles show benefits for these patients. I would like to reply to the previous question as well about the lack of expectoration. We use these CATR techniques with such patients, and we also use autogenous drainage. What does that mean? These are respiratory techniques whereby they are able to modify their air volume. Pulmonary rehabilitation for these patients only brings advantages as for other patients with pulmonary diseases. Thank you. Thank you, Dr. Camelia Pescaru. Ladies and gentlemen, dear guests, we're at the end of today's session. Before we move on to the Q&A session, I would like to remind you the following. We received 3 questions online. They are all for the pediatrics section. I know that we will tackle this section tomorrow, but I will ask the questions and it's up to you to decide if you answer today or tomorrow. So, what vitamins to administer to children? So what vitamins do you administer to children? The second question, are there children that only get Kaftrio and Kaliteko without aerosols? And the third question, what age shall we start with Orkambi or Kaftrio? If someone who specializes in pediatrics wants to reply today, that's fine. If not, you can reply tomorrow, let me know. Would a pediatric specialist quickly, very briefly reply? So the first question, what vitamins do you administer to children? Are there children that only receive Kaftrio and Kalideco without aerosols? And what age should we start Orkambi and Kaftrio? The essential vitamins are obviously the A, D, E, and K, liposoluble, separately or in complexes. The second question, are there children that only get Kaftrio and Kalideco without aerosols? The answer is no. In the treatment standards, The standard treatment with aerosols, vitamins, pancreatic enzymes, physiotherapy is kept. To this, we add the modulators treatment, so nothing is interrupted, nothing is stopped. There's no rivalry between the two, there's complementarity. Thank you. And what age do Orkambi and Kaftrio start? Orkambi starting 1 year and Kaftrio plus Kalideco. For the time being, we start at 6. But hopefully we can start at 2 years old very soon. Thank you, Doctor. There's one more answer, apparently.
Just a very brief reply. For tomorrow, there will be sessions on gastrointestinal manifestation of CF, diabetes. We will have a talk about CFTR modulators and what to do with the standard treatment of CF. So this will all be handled in detail tomorrow.
Thank you so much. Mulțumim. Le spunem
thank you. So I'm saying this to our online followers. We'll approach these topics tomorrow, so stick around. We're approaching the end of today's meeting. I would like to thank you once again, Doctor. Juana has a certificate for you and a trophy. And I will ask Trudy to come here on stage. And I think we have Alexandru Crișan, our kinesiotherapist. Please come here on stage. Join us very briefly. Thank you. And for physician Cristian Wancho, we have one more. Thank you. 2 more things before we leave. Please don't forget about the event survey form. Please fill it out and put it outside in the box. At tonight's gala dinner, we'll have a raffle. And we're going to draw one form next. So you have a free ticket for next year's Kosovo conference if you win the raffle. We have our wooden trophy with the lungs and those round discs at the entrance of the room. Please write your messages there as a symbolic gesture. That's about it from me. Thank you very much for being here today. You're all welcome at the gala dinner starting 7 sharp. We'll have a very interesting program. And don't forget, tomorrow morning we start at 9 sharp. The organizers kindly ask you to be here on time. We have a short day from 9 to 2 p.m. We have a lot of speeches, so to all speakers, please review your material and abide by the time out of respect for everyone else and for all the flights that we need to catch and whatnot. That's it. Is there anything else for today? Have a wonderful afternoon. See you at 7 at dinner. All the best. Bye-bye.